Hello everyone. Today the topic which we're gonna study is idiopathic inflammatory myopathies. So what is idiopathic inflammatory myopathies? These are non-suppurative, non-infectious inflammation of skeletal muscle which is characterized by necrosis, fibrosis and degeneration of muscle. Mean that it is a disease in which there is a chronic inflammation of skeletal muscle but will be a no history of infectious and separation, and as a result of this inflammation there will be necrosis, fibrosis and degeneration of muscle. It is primarily divided into two types on a basis of involvement of skin. If the skin is not involved, only muscle is involved, it is called as a polymyositis. But if there is an involvement of skin along with muscle, this is called as a dermatomyositis. Now come toward the pathogenesis of dermatomyositis and polymyositis, that how this disease is produced. Remember that the actual cause is unknown. We do not know what caused dermato or polymyositis, but there are several hypotheses which suggest that it might be the cause of these diseases. The first one is an autoimmune mechanism. It suggests that due to autoimmune reaction, there will be a production of this disease. The dermatomyosite may be produced by a humoral immunity, and the polymyositis can be produced by the cell mediated immunity. Other than autoimmunity, these diseases can also be caused by virus such as Coxsackie, rubella, and influenza virus. These diseases are also associated with malignancy such as bronchiocarcinoma of lung and the ovarian carcinoma. But remember that the malignancy is most commonly associated with dermatomyositis. Apart from these, certain drugs also cause dermato and polymyositis. Predominantly include penicillamine and zidovudine. Zidovudine is an antiviral drug. Now come toward the clinical feature. Firstly, we will study the clinical feature related to muscle which occur both in dermatomyositis and polymyositis. Later on, we will study the skin manifestation which occur only in dermatomyositis. So the first muscle related complication is the slow onset of symmetrical muscle weakness. So what is meant by symmetrical? Symmetrical mean that the both side of a body will be involved, and the muscle which is predominantly involved are the proximal muscle. What are the proximal muscle? Proximal muscle mean that those muscle which are more close toward the midline, such as neck flexor, shoulder and pelvic girdle muscle. Due to weakness of these muscles, the patient will have difficulty in rising from chair, climbing stairs and combing hair. But remember that the fine hand movement will intact because the fine hand involves distal muscle and it is not involved in dermato or polymyositis. But in later on in very severe disease, it can involve a distal muscle, but it is usually not involved. Other than muscle weakness, there will be a myalgia, which is a muscle pain and it occurs in about 33% of the patient. Apart from these manifestations, there will be also a dysphagia. Dysphagia means the difficulty in swallowing. So, due to the involvement of a striated muscle of esophagus, there will be a dysphagia. It can also affect heart, joints, and lung, leading to congestive heart failure, arthritis, and interstitial lung disease. So it was all about the clinical feature which occur due to muscle involvement, and it occur in both dermatomyositis and polymyositis. Now come toward the skin finding. The skin finding is present primarily in dermatomyositis. It is absent in polymyositis. So what are the clinical findings which occur in dermatomyositis? It include a heliotrope rash. The heliotrope rash is a purple discoloration of upper eyelid. Apart from the upper eyelid, it can also involve cheek, nasal bridge and knuckles. You guys can see the purple discoloration of the upper eyelid in this image. This is called as a heliotrope rash. Apart from the heliotrope rash, dermatomyosite can also cause a Gottran's papule. The Gottran's papule is a symmetrical red scaly papule. These Gottran's papule are present at hand and finger joint, predominantly involving metacarpophalangeal and the proximal interphalangeal joint. As you guys can see these red scaly papule, this is called as a Gottran's papule. These two, the heliotrope rash and the Gottran's papule, are the characteristic or the pathogenomic for the diagnosis of dermatomyositis. Other than these characteristic skin manifestation, heliotrope rash and the Gottran's papule, The dermatomyositis patient can also present with other clinical findings, such as a Malar rash. The Malar rash is an erythematous rash present at the bridge of nose. You guys can see the Malar rash in this image. The Malar rash, other than the dermatomyositis, is also present in SLE. Other than the Malar rash, the dermatomyositis also causes shawl sign and V sign. The shawl sign is a rash on shoulder and upper back, and the V sign is a rash on face, neck, and anterior chest. The shawl sign is called as a shawl sign because it covers those areas which is usually covered in shawl. You guys can see the shawl sign and the V sign in these images. Apart from that, the dermatomyositis also causes the coarsening and the fissuring of hand along with hyperpigmentation called as a mechanical hand. Now come toward the diagnosis, that how we will diagnose a case of dermato and polymyositis. The best initial test is to measure the creatinine kinase level. The level of a creatinine kinase will be highly elevated and it corresponds to the degree of muscle necrosis. Along with that, we can use the creatinine kinase level to monitor the disease severity. But remember that the creatinine kinase have three isoforms: CKMM, CKMB, and the CKBB. The CKMM is present in skeletal muscle and elevated in anything which cause muscle necrosis. The CKMB is present in cardiac muscle and elevated in MI, and the CKBB is present in brain and present in neurological disorders. Other than creatinine kinase, the most accurate test which can be performed for the diagnosis of dermato and polymyositis is biopsy of muscle. The biopsy is the most accurate test for the diagnosis of dermato and polymyositis. The biopsy will show inflammation and muscle fiber fibrosis. But remember that in dermatomyositis there will be perimysial inflammation. What is perimysial inflammation? The perimysial inflammation means that inflammatory cell, predominantly CD4 cell, will be present around the perimysium. What is perimysium? Perimysium are group of muscle fiber. So the inflammation will be around a group of muscle fiber called as a perimysium, and it is called as perimysial inflammation. Other than dermatomyositis, in polymyositis there will be endomysial inflammation. Endomysial inflammation means that there will be inflammation around endomysium. What is endomysium? Endomysium is area around single muscle fiber. So in dermatomyositis, there will be inflammation around a group of muscle fiber, and in a polymyositis, there will be inflammation around one single muscle fiber. Other than these, we can also perform electromyography and MRI. Electromyography will be abnormal in about 90% of the cases, and the MRI will show sign of inflammation. Apart from these, we can also perform certain antibody tests. These include the anti-synthetase antibody. The anti-synthetase antibody is also called anti-Jo antibody. It is more specific. It is present in about 30% of cases, and it is predominantly involved or predominantly produced when there is a respiratory muscle involvement. So when there is a high titer of anti-synthetase antibody, there will be a respiratory muscle involvement. Other than anti-Jo antibody, there will be also positive anti-nuclear antibody, anti-signal recognition particle, and anti-Me2 antibody. Remember that this anti-signal recognition particle are predominantly present when the dermato and polymyositis patient present with cardiac manifestation, and when these antibodies are positive, there will be a poor prognosis. But in contradictory, when there are anti-Me antibody present, the patient will have a good prognosis. Now come toward the treatment of dermato and polymyositis, that how we will treat a patient. Corticosteroid is the first line therapy for the treatment of dermato and polymyositis. If the patient is not responding to corticosteroid, we replace the corticosteroid with immunosuppressive agent. The most commonly used immunosuppressive agent is methotrexate, azathioprine, cyclophosphamide, and chlorambucil. Along with that, we can also use IVIG, IV immunoglobulin. So it was all about the treatment of dermato and polymyositis. Now let's revise what we have studied up till now. We study idiopathic inflammatory myopathies. It is non-suppurative, non-infectious inflammation of skeletal muscle. It has primarily two types: polymyositis and dermatomyositis. The polymyositis and dermatomyositis have some common feature, such as symmetrical muscle weakness, myalgia, increase creatinine kinase, increase ANA, anti-Jo antibody, and EMG changes. Apart from that, the polymyositis and dermatomyositis have certain distinct feature, such as the polymyositis is usually a cell-mediated process. There are no skin finding in polymyositis, and on biopsy there will be endometrial inflammation predominantly involving CD8 positive T cell. While in dermatomyositis, there are some distinct features such as there will be a humoral immunity, there will be a skin finding such as Helitrope rash, Gottran's papule, Malar rash, shawl sign, and V sign. Apart from that, the dermatomyositis is associated with malignancy, predominantly lung carcinoma in male and ovarian carcinoma in female. And on biopsy, there will be a perivascular or the perimysial inflammation, predominantly involving CD4 positive T cell. So it was all about the idiopathic inflammatory myopathies. If there are still any question, you guys can ask.